Welcome, everybody. Good morning. So I've been asked to speak about mainly glass and Wi-Fi. Now, where did they come from? Well, Wi-Fi was reasonably well established in 2020 when the global vascular guidelines were put forward. And what they wanted to do was look at three things within the global vascular guidelines: patient risk, which we're not going to talk about this morning, limb status, and then the new thing was really anatomical pattern. And GLASS, the global limb anatomic staging system, was born, and that's what I'm going to talk about first. I think the first thing to say about GLASS was that it was developed really through a commissioned systematic review and expert opinion. So it was really just put together on what experts thought, really. And because of that, it lacks a prospective validation. But the aim of it was really to try and improve the staging of anatomical staging for revascularization in CLTI. Now, we have TASC, and there are some other sort of ways that we can assess severity, burden of atherosclerosis in the lower limb tree. But I think the feeling of the guidelines was that probably wasn't well used within the vascular community. So they proposed putting forward a system that targeted really or guided inline flow to the foot of the ankle that could be used in everyday practice and would form the basis of practice-changing research. And they mainly wanted it to focus on endovascular outcomes because that's where we try and actually treat the de novo atherosclerosis. And the aim of GLASS was really to identify a target arterial path. And then through that target arterial path, determine the burden of the atherosclerosis. And the TAP was the path that was most likely to achieve inline flow down to the foot, and it usually involved the least diseased infrapopliteal artery. Now, I only put these up to show you what actually GLASS looks like, and I don't intend to go through this in detail, but essentially what they do is they grade the severity of the disease within the femoropopliteal segment, and they grade the severity of the disease within the infrapopliteal segment. If you have a severe calcification, you upgrade your grading by 1. And essentially what you then are left with is this ability to classify the whole of the atherosclerotic burden within the infrainguinal lower limb tree. So you would get, for example, an FP grade 4 and an IP grade 2 would give you a stage of 3. So what about prediction of outcomes? Well, given that this was only really put forward in 2020 with regard to the publication of the guidelines, there's limited data out there at the minute. It's a slightly immature classification system. This is a recent meta-analysis and systemic review of what was predominantly retrospective studies that have looked to try and classify the system. And essentially the take-home message from this is that the more severe your GLASS staging, the worse your outcomes from the point of view of outcomes of amputation-free survival, limb salvage, major adverse limb events, but also technical and early failure. So they concluded that GLASS was predictive of all of poor outcomes and suggested that maybe advanced GLASS stages should be treated with surgical bypass rather than endovascular interventions. A similar systematic review from the Journal of Vascular Surgery with similar sorts of findings. As your GLASS stage increases, your limb-based outcomes get worse. And again, similar sort of conclusions. So the data we have at the minute would suggest that, I don't think it's rocket science, that the more atherosclerotic burden that you have in your infrainguinal tree, the worse your outcomes are with endovascular interventions, and perhaps you should be considering surgical bypass here. What about the utility? Well, I think it's still early days for this. I think it certainly has roles within academic publications and research to allow us to try and grade and classify the types of diseases that people are treating. Do I think it will impact on practice? I think that's early days. I think if there is some better prospective data that comes out, then yes, we may start to use this within our day-to-day clinical practice to guide our practice. What about Wi-Fi? Well, this is a little bit more mature. It combines not only the degree of ischemia, but also the state of the wound and the degree of infection. And you can grade all three of these, and it produces a nice matrix that you can see below. And the matrix will determine both or estimate your risk of amputation at 1 year and your likelihood of benefit or requiring revascularization. And again, there's good data now that would suggest that Wi-Fi has value from a prognostic point of view. As your Wi-Fi stage increases, your risk of major amputation at 1 year increases, your amputation-free survival reduces, and your risk of limb salvage at 1 year also reduces. And so I think Wi-Fi certainly, the data we have on Wi-Fi is more mature, and I think is very definitively predicts poor outcome in patients. Does it impact practice? Well, yes. Within the UK, the Vascular Society have developed a best practice clinical care pathway for non-diabetic CLTI, essentially. And we put together a large number of quality improvement framework standards that are here, but you can see that one of these is Wi-Fi or equivalent classification system documented in the patient medical records for CLTI, and our target is that we should achieve that in more than 80% of our patients that come through our practice. So in the UK, we've already integrated Wi-Fi within our practice, and I would encourage people to have a look at the quality improvement framework standards that are within this document. It's easily available on the internet. Utility of Wi-Fi, well, yes, this is taken verbatim from one of our MDT notes, and you can see here that we use toe pressures and we use Wi-Fi score to give us an idea of how severe the patient's foot is. And for those in the MDT who haven't seen the patient, it gives you an idea of how aggressive perhaps we need to be in the management of such patients. So in conclusion, what about GLASS? Well, we've touched upon this already. Does it predict outcomes? The data, be it retrospective, suggests that it does, but we need more prospective studies and a reduction in the heterogeneity of the population to manage, to understand GLASS a little bit better. I think it has utility from an academic point of view, still uncertain where it fits within our clinical management processes. And with Wi-Fi, I think it does predict outcome. I think the utility is strong within clinical practice, and the impact of practice, I think we can actually use it in clinical decision makings with patients. Thank you.